and just walk through the objectives. And if there's any burning questions that you have, just pipe up.
Okay.
Okay. Okay, so here's our objectives for the Peds Neuro piece. And so I just thought I would walk through them for just a couple of minutes and make sure that there's a few things that are solid for you. So number 4 is identify clinical manifestations and therapeutic interventions for patients with traumatic brain injuries. So remember that includes mine and Vicky's, or rather Wendy's, because I think this was the, Amy, remind me, was this Vicky's presentation or was this the recorded PowerPoints?
I don't remember. I have to go back and check.
I know, yeah, I'm trying to remember if it was Wendy's recorded PowerPoints. I think it was, because then Vicky just did student presentations on the learning activity, right?
Yes.
Yeah, so it's in the recorded presentations. Okay. So the bulk of the traumatic brain injury stuff will be in the recorded PowerPoints from Wendy. But we have the pediatric considerations, and those are the developmental issues, the cognitive and emotional delay, the higher risk for drug and alcohol abuse, and some of those kinds of things. So those are going to be your pediatric considerations. Then when number 13, compare the clinical manifestations and medical management of a child experiencing meningitis and encephalitis. So when you break that down into clinical manifestations, your clinical manifestations are your signs and symptoms. What does that look like? That's the question that I love to ask with that. If I had a patient walk through the door and the doctor said they have meningitis, what are my clinical manifestations? How will that patient present to me? They'll have a fever. Generally, it's a pretty high fever. They've gotten, with bacterial meningitis, they've gotten very sick very quick, and they will look like that. Sometimes they'll be very, very pale, sometimes almost a little kind of yellowish, washed out, really ill looking. They will have a stiff neck. That's kind of a hallmark sign. They will have had a recent upper respiratory infection generally, or even ear infection. So make sure you do a really good history. You want to know what has preceded this. They will have a really bad headache, be photophobic. So lights will bother them. Just remember, someone with a really bad headache, like a migraine, lights are really difficult for them and really increase that headache. That can happen with meningitis and encephalitis also. So the clinical manifestations for both are very similar, but with encephalitis, sometimes they can have hallucinations and aphasia, so they may not be able to speak well. It might be receptive or expressive, and so they may end up being able to understand you, but not be able to speak. They have a higher risk of being in a coma with encephalitis and a higher risk of death. Bacterial meningitis is kind of then your next one, and then viral meningitis is a step down from there. Then you look at the second part, the medical management. So this is your medications and nursing interventions. So we're going to look at how we're going to treat it. What am I going to do about it? Now they've walked through my door. We've decided that this is what they have, and what are we going? This is a possibility. So what are we going to do? Well, we're going to draw some blood cultures before we do antibiotics. We're going to get a lumbar puncture or spinal tap. Specifically, those two things before antibiotics. Those will help make a diagnosis, especially the lumbar puncture. And then we're going to give them the medications that they need. They need antipyretics. We've got to get those fevers down. They need analgesics. They don't feel good. They are hurting and hurting. Specifically, nothing that will dull the sensorium. You don't want something that's going to make them sleepy or alter your neuro check. If you have a patient who's ordered Norco or Percocet or something like that, that's an opiate, even Ultram or Tramadol, it's Tramadol or Ultram, if you have a physician that has ordered that, that can even alter a level of consciousness. So I would just double check with them and say, hey, I'm kind of concerned about my neuro check being altered with this pain medicine. Could we get them Toradol? Toradol is one that's kind of like ibuprofen on steroids, and it's IV. It's pretty awesome. Then with your, what was I going to say? Oh, and then also heat and ice and some of those, keeping the room dark and quiet, clustering your cares. Think about all of those nursing interventions that will fall under your medical management of this patient. Make sure they're on droplet precautions. That's something that is very contagious that you can pass on to someone else. And with your clinical manifestations, make sure you remember that meningitis, the meningococcal meningitis, has that purpuric rash also. Other meningitis, other causes don't necessarily have a rash like that. Number 14, compare the clinical manifestations and medical management of patients experiencing various neurodegenerative disorders. I put this on here, and then I realized when I got done that the neurodegenerative disorders are actually Vicky's. They have the, I'm not sure all that she touches on, but like, I'm drawing a blank. Muscular, I don't know if she has muscular dystrophy or multiple sclerosis or Lou Gehrig's, some of those that are neurodegenerative disorders. Those will be that. So for pediatrics, we don't have a neurodegenerative one. The cerebral palsy is one that isn't neurodegenerative. Remember, that one is the one that they're born with. What you see is what you get. It doesn't go away. It's never cured, and it doesn't get worse. So I'm sorry about putting number 14 on there. Just make sure you remember that that one is more the adult piece. So 15, compare the clinical manifestations and medical management of patients experiencing various types of seizures. So this looks at our tonic-clonic seizures, myoclonic, your absence seizures, and some of the differences that are between them. So your clinical manifestations are going to be, how do they appear? What are my signs and symptoms? So with your absence seizures, remember, they don't lose consciousness. They kind of just need to be reoriented. They can have multiple. Hi, Alina. Amy's not alone anymore. Then they have your tonic-clonic seizures are going to be the ones that we've touched on the most. Those are the ones that require the most care. So tonic is when those muscles stiffen. Clonic is when they shake and they will lose consciousness. Sometimes they have just labored, very slow, shallow breathing. Other times they're apneic. So, and then make sure when we go into the medical management piece, those are all of your nursing interventions and all of your medical management. So with your nursing interventions, number one thing that you want to do is make sure they're safe. Make sure that if they are starting to fall, that you lower them to the ground. If they're sitting in a chair, you help them down. And make sure that they are not around something that can hurt them. You don't want to pull on them and move them anywhere, but you do want to move chairs out of the way, things like that they could hit. Put a pillow under their head if that's something that you can do. If they're really shaking and moving and their neck is really, really tight and you can see that their head is really moving, then it's not a wise idea to hold on to their head. But if you scoop your hand underneath and just slightly lift it, you can slide a pillow under. Good to roll them on their side if you can. Don't pull them up on their side by their arms, but get behind them and kind of roll them up by pushing on their back. That way, any secretions that they aren't managing will just run out and they'll just kind of drool and they won't be choking on that. Let's see. And then your next Next one is your ABCs. And you want to make sure that you always have suction, oxygen, and bag and mask at your bedside. Those three are super important. You want to be able to give them some blow-by oxygen so that they aren't having any problems with any anoxic brain injuries that may come from a prolonged seizure. You want to be able to give them rescue medications, but you don't want to stick anything in their mouth while they're seizing. So there are buccal medications that you can slide into their cheek, but you don't want to do that until after the seizure has stopped. So nothing in their mouth. There are some slides that are do's and don'ts. They coincide very nicely with the presentation. So those two presentations that had postictal phase care and teaching did a wonderful job at touching on the topics that need to be touched on. So after the seizure is over, the postictal management is going to be similar. You would like them on their side until they're more alert and can manage their secretions. Nothing by mouth until they can sit up, talk to you, alert and oriented, so that we know they can protect their airway. Teaching with families, she listed a really good list of teaching. So listening to that presentation again is a really good idea. Then let's see, and then identify seizure precautions. So seizure precautions, keeping them safe, making sure beds in lowest position, rails are up and padded, that kind of thing, that you can loosen a collar or remove their glasses or something like that will help them not be injured. 17, compare the clinical manifestations, and then it goes off my page. So Amy, can you help me out? What is the end of number 17?
It is, let me scroll up here. Compare the clinical manifestations and therapeutic interventions for a child with cerebral palsy.
Okay, there we go. I wondered if that was that one. All right, so clinical manifestations, that's going to be how do they look? And you have the several different kinds of cerebral palsy. So the first one and the most common is the spastic, where they get contractures and their little muscles are so spastic. So you need to make sure that with those clinical manifestations that you are realizing what needs to be done for a patient that has that particular type of cerebral palsy. So then you also have your mixed types, your hypotonic. So you have your ones that are really flaccid, really floppy. You have your ones that have involuntary and voluntary muscle movements that are really jerky. Some of them can walk, some of them can't. Some of them are completely immobile, some are developmentally delayed. And so how does that present? What does that look like for you? And then your medical management is going to be, how do you care for it? Well, with your kids that are immobile, really good skin checks, turning Q2. We've got to make sure that we help them not lay there and get a bed sore because they're not mobile. Working with physical therapy. So there's one slide that talks about all of your things to do with your cerebral palsy patients, and working with physical therapy is a really big one. Putting their braces on and off, turning them, repositioning them, good skin care, because a lot of them are developmentally delayed, and so they can't take good care of themselves. Sometimes they're incontinent, and if you have someone who's got the hypotonic, where they're very, very flaccid, they're very floppy, they don't protect their airway well, they don't sit up and have good trunk control, they need a lot of support and a lot of positioning. And if you have a patient like that that is sitting, that needs to be fed, you need them upright. You need them sitting up nice and tall with kind of like a bedroll or something padded around them in their little high chair, or seat so that they can be fed and not worry about them choking. Make sure they can help kind of with their jaw movement, but don't force feed them, don't hold them down, that kind of thing. A lot of these kids that are very, very developmentally delayed or can't protect their airway well will have a G tube, but just remember that's only if they're very developmentally delayed or can't protect their airway. Questions. Amy, do you have any questions that was anything that maybe didn't make sense or you needed clarification on?
No, nothing in particular. On the baclofen, that's the
antispasmodic.
Yeah, you were saying that they had they were itchy. There was
yeah, itchy, twitchy, bitchy, and witchy.
Okay.
And all of those rhyming words are signs of withdrawal. So when you are looking at too much baclofen, that's going to be very similar to an opiate overdose. They're going to be sleepy and they're going to not need oxygen because they won't maintain their oxygenation well. They may not protect their airway well. They can stop breathing. They'll be very lethargic and have a decreased level of consciousness. So all of those would be a big concern that you had too much baclofen and that you definitely needed to back off on the dose and call your physician and let them know you needed to decrease the dose. That's a good thought. I had forgotten about that piece. And just remember that the doses are bigger when they're oral. And so when they go to intrathecal and they put a pump in, it needs to get much smaller. And so sometimes they don't decrease the dose enough and they have a very lethargic patient that's not doing very well and they need to back off on that dose. Does that help clarify that a little bit?
Yeah, thank you.
Okay, yeah. All right, well, kind of short and sweet. It's kind of just a little review to help you remember how to break down those objectives, how to make them work for you. That's a really good way to study for it and to look at how those present in your blueprint. I had never, to be honest with you, really looked at objectives until I went to graduate school. And then I thought, oh my gosh, this would have been so much easier if I would have really paid attention to the objectives. So hopefully that helped you to walk through those and kind of break them down a little bit into how you would look at those on the blueprint. And so if our one attendee, Amy Cooper, does not have any more questions, then we'll go ahead and be done. And I've recorded this for you so that you've got it. So she's good. All right. So I hope you guys have a wonderful weekend. And next week, Vicki, and I think your burn guest speaker is on Monday, and he is just fantastic. Take notes, take copious notes, and look at the outline. There are quite a few burn questions on the next test for the next Monday on exam 3. And then Tuesday, we'll have some sensory things, some presentations. Then I will do pediatric sensory, which is super short. And then Wednesday after pharmacology, remember you have a guest speaker for pediatric simulation. His name is Marvin. He is my friend from Lifelight, and he will do a presentation on Zoom from 2:30 to 4:30. So watch your inboxes in your emails that Renee has on file. If you are unsure of that, please double check that today or Monday for sure, and make sure she has a current email for you. I will send out those Zoom links, and then he will go ahead and present that way. So I hope you guys have an awesome weekend, and I will talk to you Tuesday.